This is the first of 4 videos that will comprise and match with your outline for physical therapy in a variety of pediatric settings. They're just broken up because of the size of the videos. So in this first one we'll go through and we'll start with a neonatal intensive care unit, and that's what the second part will also cover. And then we'll cover birth to 3, and then finally school-based physical therapy in a separate video. Overall, what I want you to think about is the kind of patient problems that you see in these different settings, the goals of physical therapy, and in some cases the interventions. So as I mentioned, we'll start with neonatal intensive care unit, also referred to as the NICU. Patients in this environment, as you can imagine, are pretty high risk. These are infants whose medical problems might cause motor problems, cognitive delay, or other social or interactive deficits. So I want to go through some examples of the types of problems that you might see in a child in the NICU. So there might be lots of reasons why hypoxia occurs to a child, either before or right during or slightly after the birthing process. And that hypoxia, of course, can particularly affect the brain and brain function. So we could have a variety of maternal factors that contribute to this. The umbilical cord might get wrapped around the neck. It might collapse or get compressed. One condition that you might have heard of but might not be familiar with is called placenta previa. And as you can see on the left, the placenta should be more at the top of the uterus. In placenta previa, it's shifted down to the bottom and covers the opening or the neck of the cervix. So a couple of problems here. One is just as the child gets larger, this is going to tend to compress on the placenta layers and maybe on the umbilical cord. But certainly during the birthing process, it's going to be very disruptive and could cause hypoxia during that process. We mentioned earlier that children who are born too early, too premature, don't have mature respiratory systems. And even if they do, their respiratory passages are very small. So respiratory issues are always a big concern and may definitely land a child in the NICU. We talked about CMV before. Intraventricular hemorrhage can be a problem with premature infants within the first week of life. Intraventricular, of course, within the ventricles in the brain. So if there's bleeding into those ventricles, it'll increase pressure in the brain, and that can cause brain damage. Probably also heard of this, baby jaundice, also called hyperbilirubinemia. So hyper meaning excessive or elevated. Bilirubin is the component we're talking about, and emia means it's in the blood. Bilirubin is a component that's created as a byproduct or a metabolic waste product when old red blood cells are kind of broken down and gotten rid of. And the bilirubin has to be broken down also by the liver and then excreted. And in these infants, the liver isn't able to do that. Now this condition generally is pretty self-modifying, so within a week or two, but in the meantime, in order to prevent the bilirubin from reaching toxic levels where it can have really serious impact on the child, the UV lights actually can break down the bilirubin into a component that can be excreted by the kidneys. Viral infections, one example would be HIV. Infants born to a mother who has HIV have about a 30-35% chance of acquiring HIV themselves. So that can range anywhere from 10 to 40%, but about average about 30 or 35% chance. We mentioned alcohol use by the mother when we talked about teratogens. That may result in a child with fetal alcohol syndrome, and that child may need to be in the NICU for a while. Some of the changes, as you can see, the alcohol definitely affected development of the head and the face, and also in some cases the brain. The head and the brain tend to be smaller than normal. We tend to see what's called a flat facial profile. So we see in the upper lip, for example, that little divot that comes down between the nostrils is not really there. The upper lip is very thin. The ears are small and set low on the head. And we typically can see a little fold on the inner angle of the eye. So in this slide on the right, you see a mannequin designed to have these features, and then on the left you see a child with really striking similarity. It definitely kind of shows most of those features on the eyes and the upper lip and the mouth and the face. There are some GI problems. One of them is a type of inflammatory bowel problem called necrotizing enterocolitis, and it, of course, would disrupt or interfere with the child's ability to take in nutrition. There can be visual disorders. We'll talk later when we talk about pathologies about brachial plexus injuries. There can be orthopedic problems like a club foot or a hip dislocation. So a lot of those conditions we'll talk more about, but my point is that there's many wide-ranging conditions for which a child might end up in the NICU. And so as we're thinking about how we would treat that, I guess I skipped neonatal drug withdrawal. Sorry about that. And this is really important because, unfortunately, it's a growing problem again. Some of you may be aware in the 80s and 90s there was a pretty high incidence of babies born to mothers who abused cocaine, and so they were called crack babies. Now, unfortunately, we're seeing a resurgence of babies born to mothers who have overused opiates. So these could be prescription painkillers like Oxycontin or Vicodin, and they could also be heroin or methadone. But essentially, because the mother has taken these opiate medications throughout the pregnancy, the child is born actually addicted to them. So has to go through a long and painful withdrawal process. This is definitely a rise in concern again. There's been an increase from the year 2000, so in about the past 15 years, a five-fold increase in the incidence of babies born with neonatal drug withdrawal. So definitely a concern. So that's the last thing I wanted to bring out, different examples of conditions for which the child might be in the NICU. And as we look at then how we want to approach a child in the NICU, I want to point you to a theory that is explained in your Tecklin book. So hopefully you've read through this, and we'll read through it again. It's called the synactive theory of infant development or behavioral organization. And this is an example of a systems theory, just like you talked about systems theory last semester in neuro. The basis of the systems is the autonomic nervous system, which is the system that's going to create physiological stability. In other words, it's going to regulate heart rate, blood pressure, temperature, respiratory rate, anything you can think of for which we normally want to stay within homeostasis. Motor organization, think about muscle tone as well as normal volitional activity. Behavioral state organization refers to the infant's ability to kind of get into normal sleep-wake cycles. Attention interaction means when they're awake, they have periods of time where they're willing to interact and pay attention to their environment, other times when they're a little more quiet. And then just finally, above all, self-regulation, the ability to regulate themselves as an organism and their interaction with their environment. So we'll talk about how this impacts physical therapy in particular, but when we're looking at children in the NICU, everything should be designed to help promote their ability to regulate themselves. We have to remember that they've prematurely, early, been taken out of that very supportive uterine environment, which, as we've said many times, it was dark, it was quiet, it was warm, it was supported, and now they're into this literally cold and bright and loud world. So we want to make sure that we support their ability to stay self-regulated within this new environment that they're in. And toward the end of this video, there'll be a little video you can link to where practitioners and parents are talking about the NICU and the philosophy behind that. So that'll give you a little bit more. This is just another picture out of your book, and it does talk about the development of the child, and the interaction with the environment. And here's the intrauterine environment, and then the extrauterine environment. So remember, as they're transitioning, here's the isolette, the little place that they'll be. I'll show you a picture of that in a second. And then within all that, development is proceeding. And so the child has to be able to, we want to smoothly couple developmental improvements, changes, with changes in the environment. And so when the child kind of abruptly gets transitioned from one environment to another, and also may have some developmental issues, then that can make it more challenging. So we just are trying to optimize their development. So our goals of physical therapy intervention within this are to normalize their muscle tone. We want to facilitate flexor activity. Babies are born in physiological flexion. Flexion predominates for a while, and so we want to facilitate that. We don't want to see a child whose arms and legs are kind of splayed out, low muscle tone, not touching their midline. We want to facilitate normal midline flexion, touching the body, things like that. We definitely want to promote that behavioral state organization that we referred to before. We want to give them normal sensory experiences. And again, for a child who's born prematurely, those normal sensory experiences are hard to come by. They're in a loud environment, they're in a bright environment, so we need to manipulate the environment. They're not ready necessarily for a lot of tactile input. Again, they're in an environment, they're within the amniotic fluid, kind of floating around. They're not ready for a lot of tactile experiences, and they get a lot of negative ones in the NICU. You'll see some pictures of babies with lots of tubes and things in them, and so we want to try to help normalize those experiences, sensory experiences. We certainly want to prevent any orthopedic or other types of preventable complications. We want to manage any musculoskeletal issues that exist. And ultimately, we want to help the child transition from the NICU into a home environment in a successful way. So we'll talk about how we're going to do all that. This is just a little summary table, and it gives some examples. It takes 3 of the systems, the autonomic, the motor, and then the state system. And it shows you what it would look like if the baby wasn't doing well, and kind of what our goal would be. So our goal, of course, would be, for example, in respiration, smooth, regular respirations. So during treatment, we may see that the child has excessive or rapid respiration, or that they are gasping or having excessive pauses. So that would tell us that our treatment was stressing the child too much. We want to look at their coloring, which is going to give us an idea of their effectiveness of their cardiac output. From a motor standpoint, again, we don't want to see fluctuating muscle tone or flaccidity or hypertonicity. We want to see nice normalized muscle tone, smooth movements. We want to see normal primitive reflexes like the sucking reflex, hand hold, finger grasp, those types of things. And then finally, we want them to have nice, well-defined pattern between sleeping and waking up. You know, all babies need to get into a rhythm, and we don't want to see them have a lot of trouble with their sleep-wake cycles. And then when they are awake, we want to see them being able to interact and focus and be able to interact with caregivers in their environment. So these are some examples of things that would help us know whether or not we were seeing a stressed or a stable infant in the NICU. So we're going to go on into, we're going to stop this one here, and we're going to go on to part 2, where we'll talk about specific physical therapy interventions. In this video, NICU part 2, we are going to cover physical therapy interventions that would be delivered in the NICU. Now sometimes this is confusing, so I just want to highlight there are 5 different interventions we're going to talk about. And if you look on your outline, you'll see the first one on the bottom of page 3, therapeutic handling. Second and separate one is therapeutic positioning. That's number 2 on page 4. Number 3 on page 4 is feeding. Yes, physical therapists do feeding. On page 5, number 4 on the top is parent education. And then right below that, number 5 on page 5 is meet infants' needs for trust and confidence. Those are the 5 interventions. All the information underneath the 1, 2, 3, 4, and 5 are examples and descriptions. So please make sure you're clear on what we're talking about. So often what gets confused for students is the difference between handling and positioning. So handling is when you have your hands on the child. You're holding them, you're doing something with them, but you are handling. So you might be positioning them as you hold them, but you're still handling them. Positioning means you're not hanging on to them anymore. You're using towel rolls, bolsters, they're laying down, they're sitting up, but you're not holding them anymore. That's positioning. So we saw the term isolette before. This is an isolette. So in a NICU it would be pretty common for a child to be in an isolette, and that way the temperature, sound, and lighting can be controlled. And then caregivers may have to just access the child through the little holes like that. So some of the things that we want to accomplish is we want to try to decrease extensor activity. So we want to do things that facilitate flexion posture. And I like this, well, she's not holding her. This would be positioning. This is handling. So this is a good picture to show the difference. Handling, positioning. So we want to do things that facilitate a flexed posture. Remember physiological flexion. So we don't want the arms and legs kind of flopping or laying splayed away from the body. We want to tuck the legs underneath, so if the baby's in prone, we're holding them in prone, we want to have their hips and knees flexed, so that gives a nice posterior tilt to the pelvis. We want to tuck the hands in. You see how he's touching his face. So this is a really nice handling posture. I think this is just an interesting picture to illustrate. They probably took it for the size differential, but I think it's also interesting. You can see the light little layer of hair that's present on the body in utero, and usually by birth that's gone, but it's still here. And you can see the wrinkling up here above the wrist, showing that there isn't much subcutaneous tissue yet in the baby. So they're going to have trouble with cushioning of bony prominences and also with temperature regulation. This is a nice picture of handling, more in a sitting or upright position, but the person is using their lower hand here. They're going to be posteriorly tilting the pelvis, again, to get the spine flexion and keep the legs up tucked against the body. They're using the hand here, obviously, not just to keep the head upright, which the child wouldn't have head control, but to make sure that the chin is tucked, the head's not back in a hyperextended position or forward head position. You can see she's using her fingers to keep the baby's arms more toward the midline. So we want to make sure we're doing that. I don't have other great pictures. It would be nice to have some videos of handling, but if we were doing some handling with bed mobility, for example, we'd want to facilitate counter rotation. We could do that in a side-lying posture to dissociate or separate the movement between the shoulder girdle and the pelvic girdle. We go back to this prone position. We can use this as a way to facilitate weight bearing and proprioceptive input into the joints in both the hips and the shoulder girdle, as well as into the head and the neck area. And of course, in sitting, head righting, as well as doing some joint approximation through the lower extremities here. A lot of tactile input, and again, I know you guys talked about a lot of these things last semester in neuro class about how you use your hands for appropriate tactile input to either calm or to facilitate arousal. I'm going to show you swaddling in a little bit, a picture of that, but basically it's kind of tightly wrapping the child in a light blanket. It puts them in a flexed posture, and then again you can kind of freeze your hands so you can do other things, maybe with the head, or you could just do some rocking if the child needs some calming activity. And certainly something you can teach the parents to do as a way to just bond with the child. So those are some examples of therapeutic handling. And I'd encourage you to pause the video now, and you can listen to caregivers and parents talk a little bit about the NICU and the types of things they do and the rationale behind the way they deliver care. Okay, so you're back. And we are going to talk then about therapeutic positioning. So remember, again, this is when you're not holding them, your hands are not on them, but we still want the same principles to be followed. We still want to facilitate flexion. We want to normalize their muscle tone as much as we can, so we want to think about primitive reactions we might be stimulating with the head or the head in particular in different positions, the head or the body. So let's take side lying. Side lying is a great position, and we saw that really back in the very first picture. I'll take you back there in a second. But we have the baby supported with a towel roll in the back, and also we have one under the hips here to promote the posterior pelvic tilt. It's also called elevating the pelvis, creates hip and knee flexion. And then of course just the being in side lying, the weight of the arm and the weight of the leg will draw them to the midline, and so that works really well. So let me take you back, and you can kind of see in this side lying position, I'd like to see a little more hip and knee flexion here, but it does allow the baby to, their arm comes across, gives them nice midline, gives them good tactile experience with the rest of their body. In a prone position, we're going to see this is going to seem pretty redundant, but again, we want flexion, posterior pelvic tilt. We want to tuck those legs underneath. You should definitely not see an infant lying prone whose legs are straight out behind them. So we want to tuck those in. Certainly want the arms tucked in, and of course you can see facilitating some weight-bearing input into the hips and the shoulder girdle, and also onto the head and neck area. And we saw that also in the handling position. In supine, then of course we're going to use bolsters again. We want to tuck one up underneath the hips and the knees to elevate that pelvis, posteriorly tilt it, keep the hands in midline, keep the feet touching each other, keep the baby's head in midline. So here's an example of not great positioning. The baby's head is not in midline, and so it's kicked off. What's the name of this reflex? Right, ATNR. What does the ATNR stand for? Asymmetrical tonic neck reflex. Good. So when the baby's head's turned, the limb on the skull side goes into a flexed posture, and this limb on the face side goes into extension posture. So first of all, what's bad about this is obviously this does not promote midline activity. And if we look further down at the legs, they're kind of out in this splayed or frog-legged position, and this is not what we want to see. We'd want some bolsters on the side. We want that head in midline. We'd want to tuck those arms in. So here's some better examples. Again, on the right-hand side, I like that side-lying posture. This looks really nice and snuggly, doesn't it? A little teddy bear behind him as a positioning aid, but you can see the hands touching each other. This leg's kind of up, but he might just be reaching around a little bit. Head's nice in alignment, nice tucked position of the chin. Here we have twins in supine, and again, we can see some efforts. They've probably had better positioning and they kind of wriggled out of it, but we definitely see the bolsters around to try to keep their limbs in. Again, I'd still like to see their heads in a little more midline, have the limbs a little more onto their chest area, the same with their legs in a little bit. But nice hip flexion. This guy kind of wriggled out of this one down here, but it's like kind of escaped, but otherwise nice hip flexion, which is going to keep that spine in flexion. So a lot of positioning aids in order to keep the child in the optimal postures we want. So we want to, again, enhance those flexor patterns, work on midline orientation, promote state organization. This is swaddling, and this could be done as a positioning or as a handling technique. If it's handling, they'll swaddle and then hold them. If it's positioning, then they'll just lie them there. But again, it's just a light blanket wrapped around, helps with temperature regulation, brings the extremities into the midline, can help facilitate the flexion posture. All right, I want to talk a little bit about feeding. Feeding is a big deal with these infants. The ability to control the fine motor activity that's required in the mouth and the throat is really complicated. They have to be able to suck to draw the liquid in. They have to be able to swallow, which is again pretty complicated, and they have to do all that and then figure out how to breathe in between. As I'm sure you've all experienced, swallowing and breathing at the same time is not good. So normally this doesn't develop until very late in gestation, 33 to 35 weeks. And so when we're looking at significantly preterm infants, they are not ready to really start feeding. In addition, as I mentioned before, they may have a lot of tactile defensiveness. And you can imagine around the mouth, where the sensory receptors are really sensitive to begin with, that can be quite heightened, and so it makes it very difficult for feeding. So oftentimes we're working on just sucking and working on diminishing tactile sensitivity around the mouth area before they're even ready to start actually trying to eat. On the right-hand side, you can see, I presume his father is holding him. Skin-to-skin care, sometimes called kangaroo care, where the child is just wearing a diaper and laying against the skin of the parent. Obviously this baby is not going to be able to eat by mouth, but you can see that the dad is holding up the feeding tube. And so even though the baby's not really ready to physically eat, the parent can still feed them, they can still have that bonding time, they can rock, they have that closeness, and so it's a great way for parental bonding, and also just to get the parents more comfortable with being able to manage and take care of a child with a lot of needs. This is a great video. It's a physical therapist, and she's demonstrating how to do some side-lying bottle feeding. And so I'll let you go ahead and pause this, and when you come back, then we will finish the last couple of items for this lecture video.